You're still following all strict COVID precautions, it looks, Ranjan? Okay,
This is more radiation precaution.
Okay, that's good. Okay, go ahead, go ahead.
Yeah, it's a lead glass. Yeah. So
Very good,
yeah,
Ranjan.
just to this is a interesting. Yeah. So can we have the next slide?
That's also
Yes.
very important,
So this
Ranjan,
is
in this
a 43-year-old.
Sorry, 1 minute. That is also important to protect our heads. Yeah, because you are showing that also very well. I don't know
Yes.
which company it is, but many of us get exposed. We wear only glasses, but this looks to be more protective. That's a good thing. Go ahead.
Yes, yes. Yeah, I've been doing it for some time, Dr. Srinivas. I hardly enter without all these gadgets. Yeah.
Okay.
So this is a 43-year-old gentleman who had presented with a recent NST MI, something like, I think 3 days back. He had a chest pain and he was not in Bangalore at that time. So he is presented with an NST MI and he was not in Bangalore. He moved to Bangalore after that. So next, this is the angio which was done outside, and then he comes to us. And the angio there, I think I'm sure you can see it on the screen. It shows LAD with the critical block there, and diagonal which also has, it's like a ramus, but it is actually originating from LAD. It's around, it's within 3 millimeter, but there is a space there. It's like a early diagonal, and that also has a significant, maybe 70-80% block. The right actually is not, the left system obviously looks dominant, but I have a feeling that there is a small right which is also co-dominant, and we'll tackle it later. I wanted to show this for live and then come back there to this. Now at this point, I think we could, we could ask you what you all feel about this, and I can show you today's angio. Yeah. Can you start IVS and start recording? Yeah. Yeah. Till then we can have discussion, Doctor. Yeah.
Yeah, this is, I think, obviously a non-STEMI. We have 2 lesions, LAD and ramus. And
Yes.
I definitely think imaging is important to assess what kind of lesion you're talking about. And so we would recommend image-guided PCI, Dr. Ranjan. Anybody else would want anything
Yes,
else?
thank you, Dr. Yeah, Dr. Ramesh, I think we will be, today we have decided to do with the, this one, we have decided to do with the IVAS. Can we see the angio, today's angios? Yes, we'll show you that angios. Yeah. The right we'll see later. Let's go to left. Yeah. So this is the angio today. And one more LA caudal. No, it's not. Yeah. LA caudal. Yeah. What would you recommend, Dr. Ramesh, if this is the lesion? What strategy and...
Yeah, so I mean, I think being in India, you have great advantage of having a drug-eluting balloon. So prepare the lesion and the ramus, do a deb on that, and go for the STEM PCI provisional for LAD. Dr. Bansal?
Yes.
I would do this.
Yeah, I would. Yeah.
Ramesh, generally, with the stents being so good and so common, all of us are fixed with ideas of putting stents. Drug-eluting balloons are coming up in a good way, and especially long diffuse disease is okay. But now generally usage in our country is where you can't stent it. The vessel is too small, thin, a 2 mm vessel, and the long diffuse type of disease, that's where I think they are being more practiced. But I think if we get more data with it, where Antonio Colombo suggests you can just deliver the drug, and small dissections could also heal up, and we have to wait for the data. Randomized study is going on with him. But as of now, generally what we are following the protocol is we use drug-eluting, I'm being honest, where drug-eluting balloons where we can't stent it. But that attitude may change, as you're saying. It should change. We had a good result in OM showed by Sujata madam already. Yeah, earlier versions we would have stented it then.
Yeah, absolutely. I think keeping an open mind, I think, is what made the interventional cardiologists successful. We are now going back to just PTCA with the drug-eluting balloons, and we have seen several live cases by Dr. Antonio Colombo
Yeah.
as well, even leaving dissections which appear to be scary. But you have to believe that it'll heal up after some time, and so you have to. One of the descriptions for a interventional cardiology is the fingers of a woman and the heart of a lion. So,
Great. Ranjan, can you explain us what have you done till now?
Yeah, what we did now, we are just doing IVAS. We'll show it to you live, and yeah. So you're just coming back to DEB. Yeah, even I do use it for a couple of cases. Yeah, especially if the branch is not too big and it is provisional stenting, I prefer using DEB to side branch. And as Dr. Colombo proposed, I think most ISRs, I tend to use a DEB followed by one more stent. Yeah, one more stent. I think we could discuss that later. So I'll just show you what I did till now. So the point here was, I was thinking, I've wired both the arteries. Can we show that? Yeah. Yeah.
Another
Can we show
definite
that
indication is what you
wiring?
mentioned.
Yeah,
In
we have
ISR,
wired
we'll
both the
be
arteries.
comfortable using DEB. Yeah, please go ahead.
Correct. Yeah. So here, I think we have wired both LED and rammers. What I wanted to keep this case very simple. So I wanted to keep LED stent, little distal to this ramus or diagonal, and finish the proximal stenting, reassess the distal lesion, and if needed, put one more stent to diagonal bar ramus, provided the ostium of this is clean. Yeah, clean. Okay. Hello? Yeah. Yeah, so so what we did is, after this, we ballooned the LED. Can you show that? Yeah. LED, yeah. This is a 2.5U12 balloon. Yeah. And then after ballooning, this is, yeah. We have taken IVAS. So can we see the IVAS of LED? Yeah.
yeah, we can see the IVAS. I think somebody
Yeah,
can play it.
yeah.
And this is a very good IVAS.
Yeah,
I'm
can you
guessing
play the
it
IVAS
is.
of LED? Yeah.
It is a high definition, 60 megahertz Boston Scientific IVAS,
Yes.
which is slightly trying to
Yes,
compete
yes,
with
yes.
OCT. And you can see the 3 layers
Correct,
of
correct.
intima,
This
media,
is
and
the-
adventitia in the normal vessel right now. So, definitely the resolution
Yes,
has gone
yeah.
up to less than 100 microns with this new high definition IVAS.
IVAS, yes.
Yeah, so
so
you can
luckily, I
see-
think whenever there is a conference, Boston gives us this catheter and we are able to
Yeah.
use it.
Right. Okay, show us lesion minimal lumen diameter.
yes,
Yeah, yeah.
The clarity definitely, the newer
This
version
is
looks
old-
better
yeah,
than
stop
older.
this, please,
IVAS.
stop. Yeah, let's show the LED IVAS there and then come back to this and show this LED IVAS. Yes. Yeah, play from the beginning LED IVAS, and so this is distal LED, Dr. Ram, from the beginning, right?
Yeah.
Distal LED, can you show the fluoro?
Yeah,
it's
this-
way distal. The catheter is beyond the second lesion.
Yeah, but even here, there's a minimal lumen diameter is
Yeah.
3 by 3 millimeters, so it's a big vessel.
Yes,
Yeah.
yes.
I think you can see at that point of distal lesion
and
how
then
much it
as
comes,
you-
whether to do that or not. So the bend?
Yeah, let's see that. Yes, we are just now coming. I think
Yeah.
we are. This is the automatic pullback, so it takes little time, and we have the full run. Yeah, this is the distal lesion. This is the distal lesion. Yeah. Just hold it there. Distal lesion. Just stop. Yeah. This is This is the distal lesion. Dr. Ramesh, what do you think of this lesion? Yeah.
Yeah,
I'll
I mean-
also show the angio simultaneously.
Yeah, I wouldn't,
Distal
because
angio. Yeah.
the minimal lumen
Can you make
area
the
is going to be
fluoromedium?
more than
Yeah.
3 here. I would leave it alone,
Yes, I think what we have found is the area is 3.83
Yeah.
and the diameters are 1.97 and 2.48.
Yeah. You can
Yeah.
leave this alone.
So I think, it makes sense. Yeah, we can leave this. Now let's see what happens more proximally. Yeah. So this is, he's moving it a little faster. yeah, one branch entered there. So, yeah. And now there's a plaque there in the distal point. Yeah. Let's see the lumen area there. Yeah. Yeah. Can you stop that? Yeah, yeah. Anjo, there's a plaque which is quite away from the lesion of interest, but yeah, that plaque also doesn't look significant on IVAS. Yeah.
I think IVAS also started having this co-registration now. I think this is not there yet here. But like OCT, they also plan to improve
Yes,
upon and where
yes.
you core. But the picture which is moving on the
Correct,
angio
correct.
is left confusing, Ranjan. That is of different time. This is of different time, I think. But anyway, that
This is different time, yes,
wire looks
yes.
in the proximal
Yeah.
LED. That's why people could get confused. Concentrate on IVAS. IVAS can be made little bigger if
Yeah,
possible.
yeah. I was measuring the lesion
Lesion
here.
length, that's
they
the
can
way.
show the cine.
Yeah,
Yeah,
that dark portion of the wire is
yeah,
that 30
yeah,
mm. That's how we tend to measure it.
This is the cine
Yeah,
for
this
us
is the
to
one.
have an idea.
Oh, okay, right.
Yeah, yeah. Yeah, so I was talking about a block which is little more distal now. That point where probably one of the OEMs cross LED.
How many
Yeah,
of you
that
here would
probably is
feel
not
that you leave that
significant. Now we are coming-
mid to distal LED here? How many of you sitting in the hall would be comfortable leaving that mid to distal LED? Because
Yeah.
distal LED is wrapping around the apex. A significant portion is also there. Some of us could think of stenting without IVAS. IVAS, he showed area is quite okay. That's why we're leaving it. But without that, I think you're a little uncomfortable leaving that also. But IVAS showed it's okay. I'll leave it to you. You can tell us after that IVAS, you are doing IVAS live now or you finished it? Live, okay.
Yeah, this IVAS is not live. My IVAS right now is in the Ramas.
Ramas, okay.
And I will do that live. I'll do the Ramas IVAS live. I'm more interested in the ostium of the Ramas bar diagonal, whether it is clean or whether it is, the area where it enters. Let's see the proximal LA. The landing zone is, I think, what we need to concentrate because we have decided to probably leave the distalmost lesion and also a plaque which is in the mid region. So the stent is likely to be something like 32 millimeter. And you can see the IVAS now. This is that proximal lesion. This is the post-balloon dilated proximal lesion, which has lot of, obviously there's lot of disease, not too much calcium. And and that is the, the Ramus diagonal entering. So I would want to position my stent beyond it. There is, if you look at the angio here, there seems to be a good landing zone.
You can ask from there.
Yes, yes. Agree.
Yeah, agreed.
Yeah, yeah.
So let's, Dr. Ranjan, let's look at the Ramus now, and I think the final decision of
Ramus, yes. Right now, yes, my catheter is right now in Ramus, and let's start the IVAS, live IVAS right now.
Do you have a DFR wire for the Boston?
We have FFR or RFR. Yeah, DFR is not there. Yeah, recording. Yeah.
The
So
same Boston new
yeah.
system is having DFR, diastolic flow, fractional reserve they call it.
DFR,
Yes,
yeah.
IFR.
So this is distal Ramus, whatever you see. Okay. Yeah.
I think we wish
Distal
osteum should be
Ramus
free
there,
from disease, Ranjan. We
and-
wish, otherwise it becomes complicated. It comes
Yeah,
into
yeah.
LED, bifurcation, all that. So God is
Yes.
kind enough to you. I
Yes,
think there is good
yes.
space there. You can start the stent to just after the osteum
Yes,
and tackle it.
yes. So this is the Ramus lesion. We have not dilated Ramus, and only LED I have dilated. And this is that probably the critical area I could just inject and show. See, the flow is also very slow in Ramus now. Yeah, and this is probably the point in fluoro where it's probably very significant there. And now you can see a rim of calcium between 6 to 12. 3 to 6. 3 to 6 is where you see calcium. Yeah, and then we are now proximally, the artery size is bigger. It's bigger, yeah. And looks okay here. And this is the ostium where we are entering LED. Mild disease here, and this is LED.
LED.
Yeah, LED looks clean at this area, with a very minimal plaque. That too, not at the site of the entry, it is on the opposite wall. So I think, and this is when we are entering proximal LED. Yeah.
Take. I think one word of advice for youngsters sitting here is when you're planning imaging, always give a touch of nitroglycerin before you start imaging. Otherwise, sometimes the vessels go into spasm. You tend to overestimate the lesion diameters and underestimate the vessels. So when you put catheters, they go into spasm. Be it OCT or IVUS, please give a touch of NTG before you start taking pictures, which he did. I think as you said, the ostium is okay, and then tightest lesion is distal to it. You can tackle that separately, and then LED area is free, then you will tackle the LED. That's what is the plan?
Yes, yes, yes.
Okay.
So if you want to go for a talk, I think I can finish the angioplasty of LED and ramus and come back to you. Okay.
Thank you.
If you want, Dr. Ranjan, please show maybe an IFR or some sort of physiological assessment of the distal lesion. I think that will
LED?
make...
LED, yeah?
Yeah,
After
that
LED.
would be interesting.
Make
I'll do that.
Make
I'll
Dr.
do that.
Bansal happy here.
After stenting LED, yes.
But generally,
done. We'll do
I
that.
think we can break and we can go for the lecture. Ranjan will come back to you whenever you want. You tell us.
Yes.
Okay.
Sure.
Thank you.
So we'll show show that. Yeah. So we will show you the LED. Yeah. So one step back. Yeah. Yeah, even back. Yeah. So we took, I think, 3 into 32 stent, and this is the stent which is positioned there. As discussed, we put it after the ramus or diagonal, and then this is where we thought we'll land it. Next step, please. Next, yeah. We inflated at 16 atmosphere, and this is what we found. We post-dilated with 3 millimeter balloon, and this is what we found. So what does the team think of it? Should we do anything? I've done an imaging, but I wanted to discuss just at angiographic outcome.
You want us to comment on angiographic outcome? Looks great. What did you say?
Now I wanted to show the IVUS didn't look that good, so that's what I wanted to show. Yeah, let's show the IVUS at end of this. Yeah, this is the first IVUS, no? With after 3. So
I think after the septal, it looks slightly bigger compared to proximal to septal. That's what I can just think.
Correct. So there's some positive remodeling. So you're able to see the IVUS, right? So this is the IVUS after the 3 millimeter balloon. If you see the distal edge at around 6 o'clock, there seems to be a malapposition. As you rightly pointed out, probably there is more positive remodeling beyond septal. And although it looks circular, the area we got is 6. And we found a lot of plaque around, That means we could do more, we could make it better. There were no complications, but there was malapposition distal. Should I just focus on that malapposition? Yeah.
What stent was that?
Distal malapposition. This is synergy. Synergy, Dr. Ramesh.
No, what size?
This is the point. Yeah. 33 into 32.
Yeah, I definitely
go
with the 4O balloon,
Yes,
4O non-compliant balloon, I think is going to be very good. And proximal, it looks even 5O, but I think at least start off with the 4O.
The vessel also seems to be 4.
Correct. Yeah. So I went with the 3.5 after this. This is the 3.5 balloon. The distal, I was a little worried. The way it looked little funny there, some dye stagnation on that point. So this is 3.5 into 12, which we NC'd through and through up to 22 atmosphere, through and through. And this is the angio after that. And now we took the IVUS after 3.5. That's on your screen right now. Yeah, now the stent looks fully circular, expanded, and it seems to be touching the vessel wall completely. Except for some artifacts there. Otherwise, it looks good. And I think this is one advantage of HD IVUS, because with the normal IVUS, you're sometimes not able to see the tissue clearly. And after 3.5, it looks good. The area we got is 9. Initial area was only 6 actually, post 3 balloon. The area was 6. This is after,
Yeah.
yeah. So still there is some plaque around this. Still probably there is a scope. But I'm a little worried about one area. As you come proximal, we realize there seems to be some negative remodeling of the artery at this point. Yeah, the distal is positively remodeled, but here it is negatively remodeled. The vessel could just be 3.5 at this point, but again, proximal and distal to that, we have enough space.
Recording in
Yeah,
progress.
so I didn't want to go beyond 3.5. Yeah, at that. This is proximal just before the, just the proximal part of the stent, and soon the ramus wire will join, and there's minimal plaque here and no proximal or distal dissection. And quite, we felt this was okay.
Yeah, that's definitely.
And as Dr. Ramesh wanted, yeah.
Okay, go ahead, yeah.
Yeah, we did FFR to the distal lesion, and FFR is 0.97 and RFR is 0.93 of the distal lesion, yeah, on the screen. We have a RFR wire down now, yeah.
Okay, very excellent. That I don't think anybody would want to treat it now, right? Yes, so that's very good. We just wanted to,
yes,
angiographically it looked worse, but IVUS-wise it did not meet criteria to stent. Distal lesions, I mean, obviously now with 2.8 or less is the area that we're looking for to stent. And, but that was 3.8 by area on the IVUS, and it met non-significant with the FFR as well, or RFR.
I think that's what happens as the lesions go distal, even if they look little more, still FFRs come negative because the area supply will be less.
Absolutely.
And luckily here there is no discrepancy between imaging as well as FFR, otherwise sometimes you struggle. But I think decision making is done basically in ACS depending upon the imaging, and chronic probably by physiology. I think here both are correlating, so great, good demonstration in the LAD. I think, did you work on that ramus type of vessel or you have yet to do it? I think it's okay. I think that can be, that is straightforward.
I had to do ramus.
Yeah, that's a straightforward thing. I think you leave the osteum and
Yes,
cover the
yes,
ramus and try to do imaging later.
Yes,
I think excellent demonstration of HD
Yes.
IVUS quality imaging and then the correlation of physiology and this, and then finally good result. You want to tell any final comments, Ranjan? Hello?
No, I think it's fine. What we are planning for ramus is probably hello, can you hear me?
Yeah, please.
What we are planning for ramus is 2.7528 stent. We have measured the distance. We'll probably around be 5 millimeter beyond the ostium because there's a reasonable landing zone there. So that's what we are planning for ramus, and that should be it. Yeah. Okay. I'll optimize it with the 2.75 balloon after that. Yeah.
Thank you, Ranjan. Excellent demonstration.
Thank you. Yes.
Thank you. Can we break?
Excellent. Thank you very much.
I think before we break for tea.
Thank you, Dr. Ramesh.
Okay.